Hello everyone, I will be discussing the INICT Medicine 2020 PYQs and the other important topics regarding these questions. So question number 1 is, which of the following is the drug of choice for hairy cell leukemia? See, drug of choice is cladribine. This is very simple question, but other points that you should know is that hairy cell leukemia is associated with the BRAF V600 mutation, which is the diagnostic for hairy cell leukemia, and for this reason the vemurafenib is the another drug for this. It acts on the BRAF kinase and it is used in the refractory cases. It is not the drug of choice, only used in the refractory cases. Other thing that you should know about, that in the PS we will get these hairy cells. This is very important image based question. Then when we do the bone marrow of the patient, we will get three things. We will get the dry tap, the fried drag appearance, and the trap positivity. The most important is the dry tap. The most important is the dry tap and the trap positivity. The other causes of the dry tap which you should know is myelofibrosis, metastasis, aplastic anemia, and it can be positive, it can be seen in MDS also, but these three are the most important. The next thing is one of the most important of the confirmatory test is the flow cytometry, where we will be checking the CD103 positivity. And there is also annexin 1 positivity which is seen in this hairy cell leukemia. With this you should also know that annexin 5 positivity is seen in apoptosis. Then mostly how the patient present is massive splenomegaly with pancytopenia. So any patient coming to you with pancytopenia and massive splenomegaly, this should be one of the most important differential. Okay. Then coming to the next question. So this was again an image based question which is clearly showing this Ellis S curve. This is your Ellis S curve. This Ellis S curve is your diagnostic of pleural effusion. So we were asked what is the next step in the management of the patient. In such cases, first we will have to see whether it is transudative or exudative. For that, of course, you will do the pleural tap. So we will be doing the USG guided aspiration. There is no role of any suction or chest physiotherapy, and starting antibiotics before diagnosing the condition is useless because it can be transudative. Then there is no role of antibiotics. So then another question they can ask you in this is what are the indication for therapeutic pleural tap? There is only one indication for therapeutic pleural tap, that is to relieve the dyspnea, that is a symptomatic relief. Then the Lights criteria is used for diagnosing what type of pleural fluid this is. So there are three important markers we see in. If any of them is positive, then it is exudative pleural effusion. But if all the three are negative, all three must be negative to call it transudative. The three markers are ratio of the pleural fluid protein to serum protein. If it is more than 0.5, pleural fluid LDH to serum LDH more than 0.6, and pleural fluid LDH more than 2/3 the upper limit of serum LDH, which is serum LDH is usually 140 to 280. So protein by protein ratio, LDH by LDH ratio. Another is कि pleural fluid LDH should be more than 2/3 times. So if any of them is positive, it is exudative. Now the important MCQs regarding pleural effusion are कि whether it is transudative, the causes of transudative. The three causes that you should know are the CHF, cirrhosis, and nephrotic syndrome. Other two causes, hypoalbuminemia and Budd-Chiari syndrome, can also be asked, but they are not so important. Then for exudative, you should know that tuberculosis, pneumonia, and malignancy. These are most important. Then another is कि what are the drugs which causes pleural effusion. So the drugs that cause pleural effusion are nitrofurantoin, methylsergide, dantrolene, bromocriptine. These four drugs are very important. Only these are the most important that can be asked in the exam. There are many other, but these are the most important for your level. Nitrofurantoin, methylsergide, dantrolene, bromocriptine. Then what are the pleural effusion where we can see low pH and where we can see LDH more than 1000. Low pH is associated with empyema and malignancy. LDH more than 1000 is empyema, complicated parapneumonic effusion, and rheumatoid arthritis. The one classical finding about rheumatoid arthritis pleural effusion is that the glucose in pleural effusion is less than 30. It is seen this much low glucose is seen only in rheumatoid arthritis, a pleural effusion associated with rheumatoid arthritis. So these are the most important point. So first we will do the pleural tap, then we will decide the next course of the treatment. Coming to the third question, this is a graph of a patient which was admitted with the fever in the medicine ward. So here we can see in the week 1 there is acute stage, and before that there is an incubation period of 2 to 20 days, and in week 2 to 3 there is convalescent stage, and there are few complications, that is the uveitis and interstitial nephritis. So it is a biphasic kind of illness which is presenting in acute stage in week 1, followed by convalescent for 2 to 3 weeks. Then in week 1 there is blood culture which is positive. CSF is mostly positive in 1 and 2 weeks. Then there is a later shredding of the organism in urine. So urine positivity is coming later in the course of the disease. And the complications we have learned that uveitis and interstitial nephritis. Then another thing is antibodies are starting to rise in the week 2. So this classical presentation is of leptospira. That the answer for the question is of course leptospira. It is the acute septicemic phase which is followed by a convalescent or immune phase. Shredding in the urine, these are the important 6 questions that can be asked. Shredding in the urine is seen later in the course, and there you should know that it is spreaded by the rat urine. So they give you the image where they will show you the rats in the image. So if there is a rat in the image, and so it is most likely leptospira. Then serology, antibodies are positive in the after the first week, and for the antibody we use the MAT, which is the gold standard test, the microscopic agglutination test, where we check for the IgM antibodies. Incubation period is 2 to 20 days. Then another important question is ki the severe form of the leptospira is Weil's disease. The triad for the Weil's disease is jaundice, renal failure and hemorrhage. You should know. So any patient with rat urine kind of hint in the question with renal failure and jaundice, you should always think of leptospira. And the drug of choice for leptospira, if it is a mild condition, then it is doxycycline. If it is Weil's disease or the patient is very sick, then we will go with IV penicillin. So mostly for your exam it will be doxycycline. You have to check whether it is Weil's disease or not. In Weil's disease we usually start penicillin. So that's all you need to know about leptospira. The next question is, I have already discussed this question in the group. It is about a patient presenting with anemia with urea 86, creat 6, and there is raised calcium. Potassium is normal with bone marrow is showing more than 60% plasma cells. So this is just nothing but multiple myeloma. How to diagnose multiple myeloma is we use this criteria, not important for you. The criteria के points are important for you, that there should be more than 10% clonal plasma cells, or it should, or either it is biopsy proven. If your this entry criteria is, अगर आपका ये if there is entry criteria is fulfilled, then we go to the next, any of the following, either CRAB symptoms or the myeloma defining markers positive होने चाहिए. CRAB event में there is hypercalcemia, renal failure, anemia, bone lesions. Myeloma defining markers, the most important you should remember is more than 60% plasma cell. So if there are more than 60% plasma cell, it directly fulfill our entry criteria of more than 10% clonal plasma cells. Other two are not so important for you, that FLC ratio more than 100 or one focal lesion in MRI. You should remember these CRAB features, and what you should remember is the CRAB features and the plasma cells more than 60%. These 5 things is important for you. Then next point, these MCQs are, all of them are important. Most common antibody is IgG, most common light chain, kappa chain, most common complication renal failure, most common cause of renal failure is hypercalcemia more than light chain accumulation. This is very important. Most common bone lesion are the punched out lytic lesions. Then there is an investigation that shows M spike pattern. Then the prognostic marker is the beta 2 microglobulin. The more the beta 2 microglobulin, the poor prognosis it is associated with. Then urine finding may we guess Benz-Jones protein. Most sensitive investigation for bone lesion is MRI. Now next, coming to the treatment part. First, if the patient is presenting in a AKI or patient is not stable, we will go with the dexamethasone and IV fluids, and we can give bisphosphonates for hypercalcemia. After the patient is stable, creatinine and the urea are normal, then we will start the bortezomib regimens and the lenalidomide plus dexamethasone. Important point why we cannot start this drug in our this patient is lenalidomide itself causes it is excreted by the renal, it all itself causes the worsening, it can worsen the AKI picture. So that is why the answer for this question is dexamethasone plus fluids. Next, now another important question ki whether there is indication for dialysis or not. This is another very important question that you should know. What are the indication for dialysis? There is a simple mnemonic A, E, I, O, U. A for anuria or acidosis, which is refractory to the treatment. Electrolytes, the persistent hyperkalemia. There is intoxication of the drugs which can be removed by the dialysis, the lithium, ethanol, methanol, theophylline. Patient is in fluid overload, that is pulmonary edema, which is not responding to diuretic. These are very important. Ki patient ka pulmonary edema is not responding to diuretics. We will not do the dialysis if the patient is presenting directly in the emergency with the pulmonary edema. We will give the trial of diuretics. If patient is not responding for let's say 6 to 12 hours, we will then go for the dialysis. Then lastly, the uremia, the most important complications, uremic pericarditis, gastritis, bleeding, encephalopathy. So this mnemonic is very, very important. Many questions have been asked from this thing. Then next question is, this is a simple question. Diabetic patient with this namaste sign or the prayer sign, this namaste sign, or it is also known as prayer sign. This is seen in when a diabetic patient comes with this, then this is chiroarthropathy, where patient is unable to touch the palmar aspects. You can see the palmar aspects of both the finger, hands and fingers, patient is not able to touch. This is seen in diabetes, any type of diabetes which increases with the poor glycemic control. Diabetes can also present with duptrine contracture, but why is this not duptrine contracture? Duptrine contracture is flexion deformities of the fingers. Flexion deformities of the fingers, this one. This is duptrine contractures. Next question is, dialysis will prevent all of the following except. So, so the answer for this question, chiroarthropathy. And then next question is, dialysis will prevent. So here's a very important concept of the middle molecules that you should know. These are the molecules that are not filtered by the usual membrane that we use for the dialysis, because the membranes that we use are of low pore size, very small pore size. The pore size is very smaller than the middle molecules. There are two middle molecules that you should remember. Only one middle molecule that you should remember, that is the beta microglobulin. This microglobulin is responsible for the amyloid, the beta microglobulin amyloidosis that we study is because of this. Then there are many more molecules which are responsible for peripheral neuropathy that you should know, that there is no not important for you to know. You should know that these middle molecules causes two important complications, peripheral neuropathy and beta 2 microglobulin. There is no way we can prevent these things by the usual pore size. Only way to remove these is high flux dialysis, which is not very affordable or very cheap. This is very not used in India. So the only thing about this question you should remember is that peripheral neuropathy and beta 2 microglobulin amyloid cannot be prevented with dialysis. Okay, now the next question is, not a treatment option in Guillain-Barré. Guillain-Barré is a very important topic for your exam. We should know the best treatment is IVIG followed by Plex. Plex is nothing but plasmapheresis is also known as Plex. So best is always steroids, little bit superior than Plex. If there is respiratory distress, we can go for ventilatory support. So there is role of plasmapheresis, ventilator support, IVIG, but there is no role of steroids. Steroids are least completely useless in Guillain-Barré. But steroids are very useful in CIDP. Guillain-Barré is IIDP kind of picture. Acute polyneuropathy, we should know that acute is when it is less than 4 weeks, and CIDP when it is more than 8 weeks. So in any case of CIDP, these are very useful. Then other points about AIDP or Guillain-Barré, it is ascending paralysis, progressing within 4 weeks. Most common form is AIDP associated with anti-GM1 antibodies. Then the poor prognosis is with Aman. The worst prognosis is the Amsan variant. The antibodies are Aman antibodies, anti-GD1 and GM1. One, if you have to choose one, you will go with anti-GD1. And in Amsan is also GD1 and GM1. One, if you have to choose, you have got GM1. So AIDP anti-GM1, Aman anti-GD1, Amsan anti-GM1. Then there is the famous Miller-Fisher syndrome, which is with the anti-GQ1 antibody and the triad of ophthalmoplegia, areflexia, and ataxia. So these are the important points about Guillain-Barré syndrome that we should know. Okay. Now next MCQ was the part of internal capsule affected in hemiplegia. So internal capsule is again itself a very important topic. So I have these are the pearls from the marrow. All the important points that you should know about internal capsule in this one page. All of us know that there are 6 parts of the internal capsule: the anterior limb, the genu, posterior limb, retrolentiform, sublentiform. What you should know is what are the lesion of each of them. Anterior limb will cause the personality change because it is the thalamic radiations associated. Genu will cause the only thing you need to know is कि corticonuclear fibers होती है. This corticospinal is not important for your level. The only thing you need to know is कि it is associated with the corticonuclear fibers which represent the face. So it will cause contralateral UMN 7th nerve palsy. We know that UMN palsy of 7th nerve will involve the lower part of the face only. So contralateral UMN 7th nerve palsy. Posterior limb is associated with the corticospinal. The other two are not important for your level. Posterior limb corticospinal, it will lead to contralateral hemiplegia. It is a very important site of hypertensive bleed. If they ask you what is the most common site for hypertensive bleed, then it is your basal ganglia. In basal ganglia itself, it is the putamen. This is also a old PYQ of NEET. So posterior limb will cause your contralateral hemiplegia. Then retrolentiform. The important point is optic radiation and contralateral homonymous hemianopia. Sublentiform, auditory hearing defects. Then next point that you should know, the important question from this part is anterior, the blood supply of the internal capsule. Anterior limb is supplied by the recurrent artery of Heberden. This is a question. Genu is supplied by the Charcot's artery. Important question. Posterior limb is supplied by the Charcot's artery, anterior choroidal, and the posterior cerebral artery. These have been asked. Sublentiform is by the anterior choroidal, posterior cerebral, not so important. Retrolentiform by the posterior cerebral. The only thing you have to remember is कि पीछे वाले part से supplied by the posterior cerebral artery. The sublentiform, retrolentiform are supplied by your posterior cerebral. Then the last question for today is, which of the following is false about Mycoplasma pneumonia? So first we need to know that this is a atypical organism with no cell wall. So if there is no cell wall, the amoxiclav like beta-lactam antibodies, this option, they will never act because these act on the cell wall. They will not act on this. Antibodies are useful in diagnosis, yes, because IgG and IgM antibodies are specific for diagnosis of Mycoplasma pneumonia. Chest X-ray will show bilateral infiltrates, yes, they will show. Can be cultured in a cell-free medium, yes, is cultured in the cell-free medium. The medium is the PPLO medium, and it is also the most common cause of atypical or walking pneumonia. But the drug of choice for this thing is azithromycin more than doxy. One thing I want all of you to remember is that azithromycin is a drug which is for all the atypical ones. So if in the exam, if you are confused, the drug of choice, you forget it. If it is an atypical organism, just mark azithromycin, you will be 99%, you will be right. Mycoplasma, chlamydophilia, it can be chlamydophilia, pneumoniae, or it can be chlamydophilia psittaci and Legionella. All of these azithromycin is a very good drug, and azithromycin acts by inhibiting the 50S ribosome. You should know the mechanism of action. So the answer for the question is obviously responding to the we were asked the false statement, so responds well to the amoxicillin. It will not respond well to the amoxicillin. The drug of choice for this is azithromycin. So thank you everyone. This is the first time I'm making this type of video. Hope you all liked it.